Welcome to The Explainer. Today, we are diving right into the high-stakes world of emergency medicine. We're looking at a case involving a patient with two, ticking time bombs inside them, and it reveals this incredibly powerful principle for making life or death decisions when you have to figure out which crisis to solve first.
So here's the situation. A 65-year-old man shows up in the emergency room, and he's in serious trouble. The medical team, they jump into action, and they quickly discover not one, but two life-threatening problems. One is happening right now, an immediate crisis. The other is basically a disaster waiting to happen. So where do you even begin?
All right, let's break this down. First up, Section 1, a patient's double danger. We need to really understand the two distinct threats the team was looking at.
Okay, so problem number one is the 5-alarm fire happening right now, an acute stroke. There's a blood clot that's lodged itself in the basilar artery. This is a critical pipeline for blood at the very back of the brain. This is an immediate threat to his life and function.
But, as the doctors are running these scans, they find something else. A second kind of hidden problem. Both of the main carotid arteries in his neck, think of them as the superhighways for blood going to the brain, are severely narrowed. Now, this condition didn't cause this particular stroke, but it makes another one dangerously likely to happen down the road.
Okay, Section 2, racing the clock. With a stroke actually in progress, you can bet the priority is crystal clear, and every single second matters.
For doctors, the first thing that pops into their heads is this number, 4.5 hours. That is the golden window. It's the tight time frame they have from when the symptoms first started to give the patient powerful IV clot-busting drugs. This treatment, it's called thrombolysis, can literally dissolve the clot and stop the stroke in its tracks, but only if they move fast.
And the protocol for this? It's just this. Boom, boom, boom. A rapid-fire sequence of decisions. First, a CT scan to make sure there's no bleeding in the brain. If that's clear, and they're inside that 4.5-hour window, they push the clot-busting drug. At the very same time, they're running more advanced scans to get a precise GPS coordinate on that clot, which sets the stage for what might come next.
And this next step? Oh, this is a total game changer in stroke care. Let's say the drug isn't enough, or maybe the patient arrived outside that initial window. There is still hope. A neurosurgeon can perform what's called a mechanical thrombectomy. They literally thread a tiny catheter up to the clot and pull it out. This procedure extends that treatment window in a huge way, sometimes up to 24 hours.
So, let's move on. Section 3, shifting focus. The team has intervened, and the patient is starting to stabilize. The fire is being contained. Now their attention can finally shift from that immediate crisis to the next threat, the one that's still lurking.
And really, this gets to the absolute heart of the matter. The stroke, that's the house on fire. You gotta put it out now. The carotid stenosis, that narrowed artery, that's the cracked foundation that could easily cause another fire down the road. And you just can't start fixing the foundation while the whole house is up in flames. It's that simple.
And the narrowing in this patient's arteries, it's just staggering. We're talking more than 80% blocked in both of them. This isn't just some minor thing. This is a giant, flashing red light screaming high risk for another stroke.
Okay, on to Section 4, building a long-term defense. The immediate danger's past. So now the question is, how do you fortify the patient's system so this never, ever happens again?
Now, what's so important to understand here is that the first line of defense isn't actually surgery. It's what's called optimal medical therapy, basically a powerful cocktail of medications. This means antiplatelets to make the blood less sticky, high-dose statins to stabilize the plaque in the arteries, and aggressive blood pressure control.
And that aggressive blood pressure control has a very specific target. The goal is to keep it consistently below 130/80. That is a key pillar of this whole strategy. It reduces the constant strain on those arteries that are already compromised, and that dramatically lowers the risk of another crisis.
It's only after the patient is stable and on this whole new medication plan that the doctors even start talking about surgery. And that's a really key point. This surgery is all about prevention. It's not an emergency fix. So the decision is carefully put on hold until the patient is well on the road to recovery from that first stroke. And when that time comes, they've basically got two main choices. The classic approach is an endarterectomy, an open surgery where they physically go in and scrape the plaque out of the artery. A less invasive option is stenting, where a tiny mesh tube is put in to hold the artery open. The choice isn't random. It's completely tailored to each patient's specific health, their anatomy, and their overall surgical risk.
Okay, so let's wrap this all up. Section 5, the final principle. After everything we've seen, what's the fundamental lesson we can take away from this case?
It all boils down to this one simple but incredibly powerful rule of triage. You must address the acute, life-threatening crisis first, period. Only once the fire is out and the smoke is cleared can you turn your attention to shoring up the foundation to prevent it from ever happening again. This one principle guided every single decision that medical team made.
And that really makes you think, doesn't it? This whole framework of putting out the fire before fixing the foundation, it's a powerful model for decision-making that extends far beyond medicine. It's a really clear and effective way to prioritize when you're facing a crisis and a chronic problem all at the exact same time.